There we go. Thank you very much. I've got a few disclosures which are not of any relevance to this talk. That's my overview of the talk. So we're going to look at the overview of non-muscle invasive bladder cancer, then principles of minimally invasive treatment, and what are the options available to us in South Africa. So in the army, we had posters on the wall that said, "Ken your vyand." For those who don't speak Afrikaans, that means know your enemy. And there's the enemy there. What are the causes of cancer? There's a myriad number of causes of cancer. It's a mutational smorgasbord. And we've got things like tumor-associated macrophages, or TAMs, which they're so important in the beginning phases of your body detecting tumor and either dealing with it or making it worse. There's dysfunctional T cells. Bladder cancer is a disease of elderly people, and as we grow older, our T cells don't work quite as well as everything else doesn't work quite as well. Speak to Shingai about what thing doesn't work anymore. You have chronic inflammation. There's all the arthritises and all the other diseases that occur in people growing older, and inflammation can have a profound effect on how the immune system works, especially in hunting down tumors. There's immune evasion. Tumor cells get very clever and they learn how to hide from your body's immune system. They can change the proteins on their cell surfaces. They can send out cytokines that actually stop your immune system from working, and they can surround themselves with protein barriers to stop the immune system getting at them. Viral infections, of which we're all exposed to all the time, can alter your DNA and affect how your immune system is going to work. Smoking, we all know that that's the biggest factor associated with bladder cancers. There's about 2,000 different chemicals in cigarette smoke. And for smokers, they're bathing their urinary tracts with those 2,000 different chemicals for the whole of their lives. And then there's occupational exposure as well, like being involved in the petroleum industry and radiation and fields like that. Oncogenic changes which occur in your tissues, these are generally associated with low-grade tumors. They often occur early. They take your proto-oncogenes, which are there to protect you, and the mutational events occur and turn them into oncogenes. And then the oncogenes make your immune system go wild. But it's generally associated, especially in bladder cancer, with low-grade bladder cancers. So if you have these, you're going to have a good outcome usually. Then there's epigenetic changes that affect the environment. Modifications to the DNA. Your DNA, without changing the sequence of your DNA, but it alters the DNA, how it works. You get methylations, for example, of the DNA strands, or you can get the histones being affected. The result is that when you have these modifications, the gene gets misread, and you get aberrant proteins being manufactured. What are the causes? Every single person in this room is going to be affected by all of these. Age, diet, stress. We all have bad diets. We all have stressed. We're all growing older. Diseases. Some of us got COVID. And environmental factors. Right. So this is the classical type of picture that you see when we're looking at the morphology of bladder cancer. And you see CIS over on the left-hand side. That should have been a clue to everybody that bladder cancer is not a progressive disease. It doesn't start off as a mild, low-grade disease and then gradually get worse and worse. It really depends on what you get hit with that causes the mutations in your body. So your first presentation may well be high-grade cancer and not low-grade cancer. And you may have CIS, and you look at CIS and it Doesn't look like it's much because it's not invading, but if you were to go down to the microcellular level and look at what's going on with the immune system, you'll realize that CIS is doing devastating things to your immune system. Tumor subtypes, we've looked at this for quite a while and used it to help us decide on what's the best type of treatment. These green ones are usually the fairly good ones that will respond to treatment, the pure urothelial carcinomas, the ones where there's glandular differentiation, and also the nested variants. Those last two tend to occur at a later stage compared with the urothelial cancers, but stage for stage they respond the same in terms of treatment. Then there's the yellow ones, which are not so nice, the micropapillary, the plasmacytoid, and the sarcomatoid variants and the squamous cell carcinoma. Then you've got the really nasty one, which is where James comes in, because basically if you have that, you have a cystectomy. Otherwise, you're going to book a spot in West Park Cemetery. There was the grading system that came out originally in 1970 with WHO, which graded things into grade 1, 2, and 3 in terms of the grade of the cancer. People weren't happy with grade 2 because they could never work out whether it should be the grade 2 was going to perform well or was going to perform badly. So they dropped that in 2016 and instead came up with the PUNLMPs, which are tumors of low malignant potential, and they had low grade and then they had high grade. Now this peed off the proponents of grade 2s, and so they amalgamated it later on, and now you had grade 1 with PUNLMPs, grade 1 in terms of the cytology, but considered low-grade disease. Then you had grade 2, which was considered low-grade disease. Then you had grade 2 high-grade. So you could look at this almost like the Gleason score, where there's a big difference between a 3 plus a 4 and a 4 plus a 3. In this case here, big difference between G2 low-grade and G2 high-grade. Then there was the G3 high-grade. People then started realizing that they need to look at things more deeply, and here is a molecular marker that occurs on the cell. You see it starts on the outside, it goes through the cell wall, and it has an effector end on the inside of the cell. And this example here that you're seeing is the FGR, which is quite a common one in bladder cancer. And you can see how the FG proteins are able to bind to the receptor, and then they cause an effect inside the cell. So why are we doing this? Because it's helping us to improve our tumor grading beyond just looking at the morphology. It enhances diagnostic precision and informs us on patient management. It's key for as a prognostic marker to help us determine how well that particular patient's going to do. And it helps to have personalized treatment. In the future, not right now, but it's coming probably in the next 10 years, you're going to have your own personalized treatment for bladder cancer, if not many of the other cancers as well. When they understand all the molecular markers and the changes that are occurring due to cancer, you'll get a very, very careful recipe designed for you that will treat you. So there's the FGR mutations. These are commonly associated with low-grade tumors. So it's a good thing to have these ones. Then there's the TP mutations. They're frequently observed in the high-grade tumors, so they're not so good to see those ones. The PDL1, that's not a good marker to have if you've got bladder cancer, and it probably means that BCG is not going to work on you, and you should be looking at some other form of treatment. Then there's Ki67, P53. All of those are associated with bad prognoses. Here's an example of a slide where the pathologist stained the tumor for P53, and you can see how it shows up. And that we all know that that person's going to have a more guarded prognosis. Genetic polymorphisms. So these are being located by scientists now on the DNA. For example, the GST modifications are related to having early BCG failure. which we see in quite a lot of people who you give BCG to for some reason that currently don't understand. They respond initially and then they stop responding. And this sort of thing is one of the reasons why. NRAMP is another one, and that's linked to actually better BCG outcomes. Interestingly, BCG itself has different strains. Some work better than others. For example, the Tokyo strain and the Thai strain seem to work better, but this is ongoing research and they're not totally sure about it. But it also means that you may have to match the strain of BCG to a particular tumor that you, and its associated immunology. But that's again for the future. Right, here's a wedding cake. So this is the hybrid 3-tiered system, which offers several advantages. It's improving our risk stratification. It's hoping to have tailored treatment strategies. And it's going to give better reproducibility in future. In other words, instead of having a blunderbuss where you shoot everybody with the same weapon, you're going to have more targeted and you're going to get better results, which each time you get that same type of patient, you'll be able to reproduce it. Right, the principles of minimally invasive therapy. Why? Why do we want to do this? We're surgeons, we like cutting people up. Well, the patients don't want to be cut up. I promise you, when you get offered a radical cystectomy and an ileal conduit, your body image changes considerably and you're quite a different person. The physicians are asking for it, that patients don't undergo such radical transformations. And now, even surgeons are actually starting to question, why are we doing cystectomies on people? So, why do we do it? Because you're going to minimize tissue damage. You're going to improve recovery times from your treatment. And you're going to have target treatment delivery. I don't know why those things shrunk like that. Sorry. So for those of you who need glasses, I apologize. Right, patient selection criteria is still quite important. It's based on the tumor characteristics, on the patient's health status. Remember, a lot of our patients who get bladder cancers have got comorbid disease, and some things they will not be able to tolerate, like the famous MVAC that oncologists used to poison people with. And patient preferences as well. Patients are being brought more and more into what it is they want rather than what we tell them what they can have. Cost. This is really important. Shingai mentioned it 20 minutes ago. More money is spent per patient on bladder cancer than any other cancer. It's a lot of money. And as new therapies develop, their costs tend to escalate. So, and sometimes it makes more money for the doctor as well, as you can see in that cartoon. So the TURBT still has a role in the initial management of non-muscle invasive cancer. It's important because you're removing the tumor, the bulk of it, and you're able to analyze it pathologically and also to analyze it on a molecular base level as well. And it can be the first line treatment for patients who've got low risk disease, because if you combine it with a single dose of a chemotherapeutic agent, that can be curative for those people, and they may never have another recurrence again. This wagon wheel here shows you what treatments actually are available at the moment. We're not going to discuss them all, though I'll mention most of them. Who knows who that is? Yeah, I used to look like that before I met Shingai. No, this guy's really famous, but he actually passed away last year. That's Donald Lamb. He's the guy who brought BCG to urology. In 1976 was the first patient treated. So he's the father of BCG therapy. So how does BCG work? So it's got two modes of actions. First of all, it actually penetrates the cancer cells, and it's able to be cytotoxic itself to the cancer cells. The second thing it does is it upgrades the immune functions going on in the bladder wall itself to bring in more CD4 and CD8 cells and natural killer cells to take out the tumor. This is a more, for those of you who are really into learning all about this, I'm not going to go through it right now, but if you want to see this slide from me later on, I can show it to you. Basically, it's showing you at the top, that's the direct cytotoxic effect of the BCG. It stimulates a reaction within the cells it's killing, which releases cytokines, which then attracts in the lymphs, the T4s and the T8 cells, and then brings in the natural killer cells. And the whole event is a cascade, which eventually it should help in getting rid of the cancer. But the cancer can fight back, as I'll mention shortly. That little step off to the side with the trail is a way of the whole system being auto-regulated by the body to calm it down, because you don't want it to go completely wild, otherwise you'll kill the whole patient. Why has BCG lost its luster in the last 10 years? It's because of side effects and its tolerability. BCG is actually quite nasty, and the majority of patients get side effects from it, with the worst one being you get miliary tuberculosis. I hope none of you have ever had to see one of those patients. The treatment interruption and treatment failures result in the BCG not working as well. You have to have the BCG given on a continuous basis throughout its 2 years that you give it to the patient. And if you interrupt the treatment because of side effects like heavy hematuria or pain or something like that, the BCG starts to lose its effect and it's more likely to become refractory. Lastly, there's been this BCG shortage that came about. One of the biggest factories in the world got contaminated and they shut it down and they've not restarted it yet. We used to have BCG factory in our country, but it got shut down in the 1990s. We went from having the cheapest BCG in the world, which was about 50 cents an amp, to suddenly we're paying 4,000 Rand an amp. It was ridiculous. Efficacy of BCG. Some studies have shown that it's got a 91% recurrence-free effect at 5 years for high-grade. But that's some studies, not all studies. The median survivorship when you get BCG in the United States is only 4.4 to 5.4 years. So bladder cancer is a killer. Survivorship does improve, however, in those people who can tolerate BCG. The cost of BCG, so it's about 232,000 Rand over 24 months. So in terms of the cost of cancer treatment, that's actually quite a reasonable cost, but still an awful lot of money. Right, intravesical chemotherapy. Urologists used to shy away from chemotherapy because we had misconceptions about it. And this picture here sort of shows what urologists thought of it. Here's this miserable looking lady who's lost a lot of weight. Her hair's gone. She's clearly not happy as she gets her multicolored fluid into her veins. That's not what intravesical chemotherapy is all about. So mitomycin, which was the first drug in the more modern era, they had used chemotherapeutic agents before BCG, like Thiatepo, etc., but they never really worked very well. So mitomycin got chosen as the first intravesical drug because it's absorbed very poorly. So you don't get its systemic effects. Because mitomycin, when you inject it into the veins, is not it's not nice to be given that. And all the work in the initial first 15 years was all around mitomycin. And this became more and more common as the BCG got more and more difficult to get hold of. Then mitomycin had a problem and also became unavailable from about 7-8 years ago. And people started, there had been some earlier work with gemcitabine, but people started looking at gemcitabine more and more now as an alternative. And it worked just as well as mitomycin. In fact, studies showed it worked better, and it was much less toxic. Mitomycin is really nasty stuff. You don't want to get it on your hands. So, yeah, we're running out of time. Yeah. Right, so I will basically skip this bit and tell you that it is still quite efficacious. This guy here is Professor O'Donnell, who was the first one to look at doubling up chemotherapy in the bladder. So instead of one agent, he gave two, and he used gemcitabine, which is how it works, and he used docetaxel. Docetaxel, just very quickly, you have a whole myriad of tubules inside every cell, which change from 1 second to the next to allow the cell to be mobile. Docetaxel turns all those tubes into rigid structures, and that buggers up the whole cell. This gemcitabine docetaxel combination is probably the treatment that we in South Africa should be looking at going forward at the moment. And you can see that it works actually better than BCG. And it works in up to 42% in people who've become BCG refractory. Its cost is only that, 127,000 Rand for 2 years, so it's cheaper than BCG. Anyone who knows who this is without Googling him right now gets a bottle of wine from me. No one know? Right, no bottles of wine. Yeah, no, won't. It'll be one of my good bowls. This is William Coley. He's considered by two camps, the immunology camp to be the father of immunology and the hypothermia camp to be the father of hypothermia. This is a system that we use for putting chemotherapeutic agents into the bladder, heated up to a temperature of 43 degrees. It's being done quite a lot in South Africa now, and its effect is pretty good, and it's very well tolerated. How it works basically is a combination of making cells more permeable, allowing the cancer drug to get deeper into the bladder, and creating heat shock proteins which act as chaperones to carry tumor antigen to the T cells so they can then kill the cancers much better. Its efficacy in intermediate risk disease is actually no better than treating patients with normal therapy. However, in high risk disease, it works pretty well, but more results still need to come out about it. It's got common side effects, but they're not severe. The worst one probably is that some patients find it extremely uncomfortable. I've even had one where we had to anesthetize them each time we did it. You can get some less common but more serious side effects. It's quite costly, however. It doubles the cost of BCG, so it's 450,000 Rand over 2 years. Intravesical immunotherapy, a lot of it is still in early clinical testing. Pembrolizumab is being used now in clinical trials for intravesical therapy. Vicinium was another one, but it doesn't pass anything, so it's no longer used. And now in clinical testing is a drug we now have in South Africa, Anktiva. This guy here might win a Nobel Prize. He's a South African living in America, and he developed this drug. And Anktiva works to restore the immune system responses to BCG, including establishment of immune memory that leads to durable responses, and by causing a massive proliferation of the natural killer cells and your T cells. It's been licensed now in the US to be used in patients who are refractory to BCG. Can you explain? 2 minutes. There's the mechanism of action, which is really interesting, but I'm going to skip through it, how it works. That triangle there's developed by the company. Basically, it causes you to have memory T cells, which are permanently around, so the effect of the treatment lasts for years and years and years. It exposes the cancer cells to the immune system where they were hidden before, and it kills them. There's a Kaplan-Meier curve of Anktiva efficacy. You can see even gone through the 3 years of treatment, 59% of people have still responded, and this is in people who are BCG refractory. It does have side effects. In the US, this stuff's horribly expensive. It's 35,000 Rand an ampule, but they have a copay program in the States which allows charging only 1,800 Rand per amp. So the total cost with BCG would be about 280,000 Rand for 2 years. What else is on the horizon? We've got gene therapy. You can take interferon, which doesn't work well on its own because it gets rapidly munched up in the bladder. But if you connect it to an adenovirus, it makes it last longer, and it takes it deep into the tissues. EMDA is another form of heat therapy. There's hydrogels, which can take gemcitabine and make it stick to the wall of the bladder and make the effect better. There's nanotechnology, and there's also photodynamic therapy, which again, still experimental. They need better light, and they need better drugs to make it work. So therapies for non-invasive bladder cancer have progressed significantly in the last 10 years, enhancing the patient's outcomes and quality of life. But continuous research is necessary. Thank you for listening to me.